Hey folks, Scott Weingart here, and this is an EMCrit podcast. Today on the podcast, finally, we're going to talk about the Rush Exam 2.0, and it's been a lot of work to get it to this point. So I hope you enjoy this, and I hope you will comment and make it even better. Before we jump in, real quick, I'm going to be doing 2 free webinars, one on burnout and one on communication in the month of July. If those sound interesting to you, and again, totally free, then make sure you are on the EMCrit mailing list, because that's where I'm going to send out the dates and times for that. So please, if you're not already, join. We do not spam. The email volume is incredibly low. And I recommend the books that I'm reading and love, which a lot of people, even outside of medicine, seem to really enjoy. So if you're not already a member of the mailing list, just go to emcrit.org and sign up. You will not be disappointed. All right. The Rush exam. What is the Rush? Rush stands for Rapid Ultrasound for Shock and Hypotension. And let me give you a little bit of history on this because it gets confusing, and you'll see why shortly. So I came up with this in 2006 and worked on it with my buddies Danny Duque and Brett Nelson. And I was lecturing on it all through 2007. I published it on EMCrit in 2008. Since that publication in 2008, anytime you would Google Rush exam, it would always be the first hit, that EMCrit post. It was undeniable. There was nothing else that had that name, Rush exam, so that was what would come up. And then we published on it in eMed Home in 2009. And then in 2010, 4 years after the conceptualization of Rush, another group published on it with a similar protocol and the identical name. And before they went to press, we actually got in touch with them and said, please don't do this. This is a bad idea. And they did anyway. And so that's why there's some confusion on what the Rush exam is and who did it and where it formed. But there you go. Now you have the history. Then I revised it a little bit and talked about that with Jalen Avila. And it's been very potent. The purpose of the Rush exam was to be the medical surrogate for the FAST exam. FAST exam, you got a crashing trauma patient. You want to immediately rule out a bunch of potential sources of bleeding or hypotension. You do it less than 30 seconds and you get some answers. We didn't have anything like that for the medical patient, so hence the Rush exam. Now, a few months ago, I went to a course by Philip Rolla with Rory Spiegel and Corbin Haycock and Jean-Emile Kenny, and it was amazing. And it was a course on their nascent interface model of hemodynamics. And we've talked about that in the podcast for weeks now. And at that course, I'm like, the Rush exam could be even better. Instead of just being for crashing patients, this could be an exam that people standardize to actually do a hemodynamic assessment of their patients and rapidly get some answers. And it's all well and good if you're like a clinical physiology guru like the folks on the actual interface paper. But if you're not, it would be nice to have a guideline, a map for what you should actually be assessing at the bedside. And especially, it would be wonderful if learners who could really develop quickly the assessment skills but might not have the ability to all synthesize it could just come back to you and give you the information they found at the bedside, and then together you guys could work through the interface and figure out what's actually going on with your patient. So hence the Rush 2.0 or the iRush. The I stands for interface informed, because now we're not just doing the Rush exam for crashing patients, we're actually using it as the entree to assessing the patient's hemodynamic status, even if they're not crashing, but they're still in shock or have hypotension or both. Hence the iRush. Now, astute listeners are going to say, Scott, you're kind of losing some of the benefits of the Rush. The benefits of the Rush were it was quick, down, dirty, you got it done, and you found out the patient's life threats. And now you're going to be complicating it. I think you're actually going to be sending people astray. Similar to the FAST exam was complicated by a lot of people. And it's not necessarily a good thing because that exam was intended for patients who were spiraling. But I gotcha. So we talk about the iRush, but then there's also the CRUSH exam. The CRUSH exam is for crashing patients. It's the crashing Rush exam. Crashing Rush, hence CRUSH. And The crush exam is the rush exam you were used to. In fact, it's even a more abbreviated rush exam than I first introduced. So it's simple. The crush exam is heart for chamber size and effusion, which usually involves going to parasternal long and apical 4 chamber. If all you could get is a subxiphoid, you could make up for whichever those two you can't get. You get a shot of the IVC, not doing any measurements, just looking at it qualitatively. Is it big? Is it small? Is it collapsing? Instead of doing all the abdominal views, you just do Morrison's in Trendelenburg. Morrison's in Trendelenburg will take care of you. It will tell you if there's large amounts of fluid in the peritoneal space. It won't tell you small amounts. I don't care about small amounts. Small amounts will send me astray. I want to know large amounts. So 1 shot of Morrison's with the patient in Trendelenburg, 4 views of the aorta, and trust me, if the patient actually has a AAA, you'll see something versus, oh, I don't know, I can't visualize the aorta, and you're really in the right place doing the right thing. Chances are they do not have a significantly large aorta, or else you would see it. And then pulmonary, just to screen for tension pneumothorax. So really talking about 2 anterior views of the lungs, and that's it. That's the crush exam. It should be done in 30 seconds or less. You have a patient who's crashing, they're not trauma, do the crush. Now let's talk about the iRush. iRush, the interface-informed rush exam, it's going to be a little bit of an addition to that crush exam. And we're going to take our time and we're going to think through. Now, at this point, it would really behoove you to go to the show notes for this episode, emcrit.org/429, and print out the PDF of the iRush exam because it's packed full of information. You're going to want it, and it's going to help you contextualize what I'm going to be saying in the next 20 minutes or so. It'll really help you, I think, to follow. Now, if you're driving in your car or you're running, obviously you're not going to do that, and then I think you'll still be okay. But then afterwards, print it out and make sure it all makes sense. Now, before I go into the particulars, I have to put out an enormous thanks to Sarah Krager. I sent the iRush to her for peer review, and she went so above and beyond with amazing comments. She really brought it up to another level, and her comments were integrated into this, and it is just much better as a result of her help. So thank you, Sarah. You are a superstar and a buddy. Also, obviously, I will thank all of the authors of the interface paper, because otherwise the inspiration for this would not be there. All right, let's roll into this. Now, you're going to start your iRush with a clinical exam. You might have the ultrasound probe next to you, but start with a clinical exam because that's going to really help inform the patient's interface assessments. So you look at the blood pressure. They're not just their MAP, they're diastolic as well, they're systolic as well, and their pulse pressure, because all of those have representations on where the patient stands in their interfaces. You do a cap refill time exam. You do it right. You actually do it with a stopwatch. You occlude for 10 seconds, nice and hard. And then with a stopwatch, you actually see how long does it take. Normal is less than or equal to 3 seconds. You look at your pulse ox waveform, not the pulse ox saturation number, the waveform for quality. If it's horrible waveform, chances are the patient does not have good cardiac output. If you have it, and I think almost all the monitors do at this point, look at the patient's perfusion index on their pulse ox, because that is going to be a representation, just like cap refill time, of what's going on at the patient's microcirculatory level. You can look for modeling, especially around the knees. Distal skin temperature, usually that's going to be done by palpation. You feel the core, you feel over the patient's belly, and then you feel their feet. Or you can actually use IR, camera, or an infrared thermometer, if you want to be crazy like Farkas and I. But most of the time, it's just going to be by palpation. And then what's the patient's mentation like? And that, we're using it for a patient we already have determined they're in shock or hypotension or both. That being said, and Sarah wanted me to point this out, those same clinical exam findings are the cues to a patient in subtle shock to actually identify them as being in a shock state if their blood pressure is normal. It's also reassuring when you have a patient who might be cirrhotic with a baseline low blood pressure. If all those other things are normal, it kind of makes me think this might be that patient's baseline and not a shock state. So this clinical exam is invaluable. Get used to doing it all the time on your hemodynamically unstable or potentially unstable patients. Then we get to the heart. And the way we organize this in our head, the way the rush exam was always organized, was around high MAP, because that's usually what you want. You want a high MAP, and that's HIMAP, or H for my UK listeners, IMAP. That's heart, IVC, Morrison's, aorta, and pulmonary. So let's go through them one by one. The heart. At the very least, you're going to get a parasternal lung, and you're going to look for effusion and signs of tamponade. You're going to look for a left ventricular ejection fraction, and that could be done by visual estimation. That's usually what I would do. Or you could actually calculate it if your visual skills aren't up to snuff yet with a EPSS, E-point septal separation. And then we're going to go anterior four-chamber for qualitative assessment of the chamber sizes. Now, that's just the bare minimum. If you're capable and you have the time, then you should add on the following when they're applicable. I think for any patient you're doing a hemodynamic assessment on, you should be doing a left ventricular outflow tract VTI, especially if the cap refill time is abnormal. Now, what is that actually going to tell you? The best way to think about it, if you're not going to do a diameter of the aortic root, is it is very well correlated with the stroke volume index. And in fact, what made this so enjoyable recently is people said you don't need to do that aortic measurement anymore, just using the VTI directly. And this has been in the past, I don't know, probably 5 or 10 years. It's just so much easier. You don't have to worry about anything anymore. You just do the VTI and use that as its own measurement rather than trying to back calculate stroke volume or cardiac output. And the stroke volume index is actually a better number anyway. So you're going to do that, and we'll talk shortly on how that's going to be a really good marker of coupling at that LV interface. If the RV is enlarged or you have suspicion of RV failure, then you should do a TAPSE, which is a tricuspid annular plane systolic excursion. It's a marker of the functional status of that RV. And if you know how, a tricuspid regurg velocity, a TRV, and that will give you an analog of the pulmonary artery systolic pressure. You should do a qualitative valve assessment. We mean just throwing color over the mitral valve, the tricuspid valve. And then, if the situation's applicable, do a parasternal short axis to evaluate the septum, the interventricular septum, and to look for wall motion abnormalities. All right, so that's the heart. Then we move to the eye, the IVC, and you're just looking qualitatively for collapse, respiratory collapse, if the patient is spontaneously breathing. And then the size at end expiration, with normal being less than 2 centimeters. Now, if the IVC is plethoric, it's not collapsing, then this would be a good time, if you have the skill set, to add on additional VEXIS views. And we've talked about VEXIS on prior podcasts. The one, if you're just going to go for one, that I think you should learn to do and do in this assessment is the portal vein. Portal vein is least likely to have artifacts affecting it. It's a little bit harder to find, but if you learn this skill, that's really the one. I find the renal vasculature to be a little bit difficult. Hepatic vein is really easy, but really prone to artifactual obscuration. So portal vein's the money, and it's just the only one I do if the IVC is plethoric. So that's hard. Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Heart and IVC. Let's go to Morrison's. And so these are not abdominal views. It's just one view, and I've already mentioned that. Now, Rory Spiegel suggested, Scott, on a normal patient, we have no suspicion of bleeding and they're not hypotensive. Do we really need to do Morrison's or the aorta? And he's right, you don't. You don't need to do it. So if the patient's not crashing, you can use your judgment. Do I really need to look for peritoneal fluid? Do I really need to look for a AAA? This patient's blood pressure is good. They're showing subtle signs of shock. I don't think they're bleeding. And he's absolutely right. So if you think the patient could be bleeding or once they're hypotensive, I think the risk benefit means just do it. And if you're going to do Morrison's, then as mentioned, it's a single view in Trendelenburg all the way down to the inferior pole of the kidney. You need to see the interface with the inferior pole of the kidney, not the superior pole. You're moving down that kidney until you see the inferior pole in Trendelenburg. That is going to be super sensitive for intraperitoneal fluid. If the patient's hypotensive or you suspect bleeding, then do 4 views of the abdominal aorta. So that's HIMA, and now we get P, pulmonary. And again, we're going to get 1 view of the anterior chest on each side, and that's going to be to rule out tension pneumothorax. But on a patient that's not crashing, the more likely benefit is to assess for interstitial edema. And then I add on, as long as I have time, 1 posterior view of each of those chests, and that's going to give me more subtle signs of interstitial edema. If you could get all the way up to your anterior chest, obviously it's pretty bad. And if you go all the way down to the posterior lateral chest, then you're going to pick up subtle signs of that. All right, so that's what you're going to gather at the bedside, a clinical exam and then those high map ultrasound views. Now let's talk about actually synthesizing all of that. So we're going to go through each of the 4 interfaces first. And we've spoken about this in prior podcasts over the past few weeks, so you should listen to those as well to understand more about this synthesis. So first one I always look at is the arterial microcirculatory interface. And basically what it comes down to is the CRT, the cap refill time, and the perfusion index on that pulse ox, are they telling me there's adequate tissue perfusion? And if there is, I already breathe a little bit of a sigh of relief. There still could be bad stuff going on, but it's not bad enough that it's affecting at the tissue level yet. Then I look at my LV information and I ask, how is the LV handling its afterload? Is the cardiac output adequate? Is the patient hypovolemic? Then, if you've gotten the VTI, you could actually use that both as a marker of that stroke volume index, but also, Sarah suggests, this is her thought process time for coupling at the LV interface. So if you have a normal VTI, 18 to 22, that's good coupling. Low VTI, less than 18, is telling you the patient has low stroke volume due to intrinsic cardiac failure or low stroke volume due to over elevated SVR, systemic vascular resistance, or mitral regurgitation. If the patient has a high VTI, greater than 22, the potential causes of that are vasoplegia, high output cardiac function, and you better screen that patient for high output cardiac failure, or aortic insufficiency. We'll consider our RV interface. Is the RV function impaired? Is the RV afterload too high, i.e., increased pulmonary artery pressures? What is that septum doing? Is it D-shaped? Is it bowing out into the LV? We'll consider our TAPSE and tricuspid regurg jet measurements. We'll look at the venous microcirculatory interface. Does the venous system appear congested or collapsed? We're going to integrate Vexus, especially that portal vein. Then we look at the meta interfaces, the interface squareds, the interfaces of the interfaces. So we'll look at the LV arterial microcirculatory interface. And now with that abnormal cap refill time or perfusion index, we'll start correlating and ask ourselves, is this a secondary problem due to upstream influences from the LV, or is it an intrinsic microcirculatory problem? If the CRT or perfusion index are normal, but the patient's still hypotensive, then we have to start considering vasodilatory shock, a shock state where the MAP is going to be low, but the organs are still going to be perfused because the vasculature is wide open. And so even at that lower MAP, we're still going to have organ perfusion. If there's hypotension with decreased pulse pressure or decreased VTI, we're going to consider cardiac output issues, intrinsic cardiac or due to things like hypovolemia. we're going to make sure that after interventions, especially vasopressors, we're going to repeat our left ventricular ejection fraction and our VTI, because these are load-dependent variables, meaning that they are exquisitely sensitive to afterload. So if the afterload's wide open, then you're going to have an ejection fraction and a VTI that look good, even though the heart function might not be great. You then put them on vasopressors, and all of a sudden, the ejection fraction gets worse, the VTI gets worse. So you have to continuously reassess. And then any hemodynamic intervention, reassess the CRT, a la the Andromeda shock trial, or the perfusion index, if that's what you're using. All right, we could talk about the venous microcirculatory interface with the RV. So we're going to contextualize now our IVC assessment. And in general, if you have a non-plethoric collapsible IVC, it doesn't mean everything's great with the RV, but it means whatever's going on at the RV has not actually fed upstream yet to start affecting this meta interface. Now, this can miss RV infarct because in general, that's a passive issue where you're not going to have a plethoric IVC. But again, the tissues are still functional at that venous microcirculatory level. If the patient's hypotensive, these patients with a collapsible IVC may be hypovolemic or bleeding, but only if the clinical milieu and other indicators support it. If, on the other hand, the patient has a high VEXA score, then they might need right heart augmentation, a decrease in RV afterload, or diuresis. And Sarah warns, don't put all of your heart into the IVC because sometimes it is confounded by things like abdominal compartment syndrome, the extremes of mechanical ventilation, and I guess in some ways, overly exuberant, spontaneous ventilatory efforts. You have a patient who's really hyperpnic, but again, that's not a lie of an IVC. That's telling you the truth. That patient is, through the mechanism of extreme venous return, actually overcoming whatever might be downstream of it. But that being said, when these patients tire out or you decide to paralyze them, they could have a precipitous decline. So it's always worth considering what's going into your IVC assessment. We then have the RV-LV interface, and that's where the effects of a failing RV may actually start impairing LV function. So you could actually look at your septum, and if the septum is actually impinging on the LV chamber, then that's a really problematic progression of that RV failure. And you have to ask yourself, is the RV providing adequate preload to the LV? All right, then we could take all of those musings and synthesize them and then categorize and phenotype the shock and hypotension. I have a chart in there, I'm not going to go through it, that breaks down each of the shock types and their effects on each of the interfaces. You could take a look at that on your own. We don't have in that chart the obstructive phenotype because the rush exam should have ruled out the obstructive sources of shock. I guess except for abdominal compartment syndrome, that one you really still have to consider. But luckily, the next line in the PDF is considering other causes for a patient you've still not discovered the source of their shock or hypotension. Things like occult bleeding, gastrointestinal, retroperitoneal, abdominal compartment syndrome, dynamic left ventricular outflow tract obstruction, Addisonian crisis, toxicologic causes, hypocalcemia, and then cardiac valvular dysfunction. And Sarah really wanted me to stress that one. She says, folks who are not looking for it are going to be missing valvular abnormalities, and we're not talking about subtle ones here. We're talking about like severe tricuspid or mitral regurg, aortic insufficiency, which is a little harder to find on Doppler. So always consider it. And then at the very end of it, if you've normalized your patient's macrohemodynamic vital signs, but the patient's still showing signs of shock, cap refill time, lactate, etc., then you have to start considering primary microcirculatory dysfunction, whether the patient has hemodynamic coherence. And Phil Rolla is putting out a paper on that in the coming weeks, and we will certainly have a podcast on that when that paper comes out. So there was a lot there. that is the iRush exam. Now, I'm super curious to hear what you think, what you would add, what I missed, what you want changed, because this can only keep getting better. We'll put out Rush Exam 2.1 based on your feedback. Now, the last thing I want to mention is the skills that I think, if you buy into this iRush idea, we need to consider the baseline in emergency medicine and critical care. So absolute basic is all components of the CRUSH exam. Every single person, I don't care if you're 78 years old in emergency medicine, should be able to do the CRUSH exam. I think it's just sine qua non. You can't consider yourself capable of taking care of really sick patients if you can't do the basic CRUSH exam. Now, the additional modalities that I consider essential, but I can understand if you're not an ultrasound type person, though everyone at this point should be. Maybe you haven't developed these. I still think you could be practicing in an ED or critical care unit and not be able to do these essential ones, but I think you should be. And anyone going through training now, certainly, residency directors, ultrasound directors, these are the ones you got to make sure you teach your people. I want everyone coming out with these skills. So you should be able to perform an LVOT VTI. You should be able to perform a TAPSE. You should be able to perform valvular assessment. We're just talking color Doppler. We're not talking about necessarily measurements at those valves. We're looking for gross regurg. You should be able to do a Vexus, especially that portal vein. You should be able to do a qualitative assessment of the interventricular septum, and ejection fraction, LV ejection fraction, either estimation or measurement. You should be able to evaluate that LV for gross regional wall motion abnormalities. Those I consider essential. I think everyone in training now should make sure they graduate with those skills. Desirable, I think more advanced stuff, especially the measurement of the TRV, the tricuspid regurg jet peak velocity, be a good thing to learn. Not too tough, especially if you're already doing VTIs. So I'm sure there are some other desirable ones. Now, there's like this guru level when I go to Phil's and the others' courses. They're doing stuff that is just outside my skill set. Like that, I don't think I'll ever develop. I don't even know if I want to develop it. They're doing crazy, crazy stuff. So maybe we need another category of ultra advanced skills. But I think this list, and I'll put that in the podcast show notes, I think this should be the roadmap for where we go on hemodynamic ultrasound. All right, so much there. I want to hear what you think. Please, please, please tell me what you think. Remember to sign up to the mailing list to get notifications of those 2 free webinars that are coming this month. It's been Scott Weingart for the EMCrit podcast saying bye-bye. As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.